Hello, everybody. I think that you can probably hear me. I certainly hope you can. I see some questions. Everybody on this call. So first of all, good morning, good afternoon, good evening, depending on where you are in the world. My name is Emily Bath. I'm the program director at AVAC, and I am a co-convener with ICW East Africa. I and AVAC co-convene the Civil Society Advocacy Working Group on Hormonal Contraception and HIV. So it's a real pleasure, and I'm very grateful to be welcoming everyone to this call. We have a tremendous number of people who've expressed interest in this really important issue, and a lot of great speakers lined up for it. We're going to take just 1 or 2 more minutes just to dial out to everybody, and then we are going to get underway quite briskly. We have a couple of different ways for you to troubleshoot. Tech support, if you have the audio for this call is phone only. So you need to have your browser open from the link that you received in registration to follow the slides, and then you also need a phone connection, which can either be a dial out that you triggered when you provided a number when you registered, or dial in with a toll-free list of numbers. And I will go ahead and repost the toll-free list in the chat section. You are in a global mute now. When there's question and answer time, we will put up the instructions for unmuting. It is *7 to unmute and then *6 to remute. There are other ways to ask questions as well that you'll see as the conversation goes on. So thanks very much to everybody for joining us, and I am going to be, after this brief welcome, turning it over to Margaret Happy, who is the coordinator of the Civil Society Working Group on Hormonal Contraception and HIV, and a dedicated and fierce advocate for women's sexual and reproductive health and rights, particularly in the realm of HIV, and then within that has really helped shape the dialogue on this issue, as she will be doing today. So I am going to, it looks like we actually are having quite a number of people already joining successfully. So what I'm going to do is just go ahead and turn it over to Margaret, who I believe is already on the line and unmuted. Margaret, can we hear you? I'm just looking. Margaret, it would be *7 to unmute your line. See, are there other presenters or someone who can unmute who can confirm that you can hear me?
This is Jared Bacon. Can you hear me?
Oh, thank goodness. Yes, I can hear you. Chelsea, are you on the line? Can you hear me?
Yes. Can you hear me?
I can. That's great. Okay. That solves a little bit of my momentary existential crisis. So, Margaret, can we get you on me? I'm checking. All right. I am going to solve the problem of connecting Margaret. And what I'm going to do, she will be guiding us through the phone, but I don't want to lose, for the rest of the call, I don't want to lose more time. So what I'm going to do is myself introduce Chelsea Polis. For those of you on the web, you will be able to follow her slides. This whole call is going to be recorded, and I will check with presenters afterwards about making the slides available. Chelsea Polis is a senior research scientist at the Guttmacher Institute. She is a scientist advocate. If you don't follow her on social media, I highly recommend it. And also has really, really led the field in trying to look at the available data on the questions around hormonal contraception and HIV risk, particularly through her leadership and participation in the systematic reviews of available epidemiological evidence. And we're really delighted to have her here today to talk us through the most recent data. So with that, over to you, Chelsea.
Great. Thank you so much. And before I get started, Emily, am I to advance the slides on my end, or is that on your end?
I believe that's on our end, so if you can just cue us, we will do it.
Okay, sounds great. Okay, well, thank you so much, and to everybody who's joining today, hello, and thank you for your interest in this subject. And of course, thanks very much to the webinar organizers for inviting me to present. I'll be providing a brief overview today of our recently published systematic review, which assessed epidemiological evidence on whether various methods of hormonal contraception increase a woman's risk of HIV acquisition, and I'll also share just a few thoughts at the end about implications of what we found. Next slide. And before delving into the review, I'd really like to gratefully acknowledge all of my co-authors on this systematic review who are listed here for their excellent contributions to this work. Also, I'd like to thank the many investigators who assisted us throughout the process of this review by providing additional information or analyses about their studies. And we're also, of course, very grateful to those individuals who have participated in these studies that have advanced our knowledge on this topic. Next slide. Empowering women and couples with the tools necessary to prevent unintended pregnancy and avoid sexually transmitted infections, including HIV, is critically important for individual and public health. Various hormonal contraceptive methods are highly effective for prevention of unintended pregnancy, and in this way, hormonal contraceptives contribute to the prevention of various negative outcomes, including maternal mortality. However, some studies have suggested an association between specific hormonal contraceptive methods, especially injectable DMPA or depo-medroxyprogesterone acetate, and HIV acquisition in women. Next slide. To address this concern, we updated a previous systematic review. So our last review contained all relevant studies published through January 15, 2014. And this new review that I'll present today incorporates all new evidence that was published after that end date of our last review, January 15, 2014, through January 15, 2016. So it incorporates 2 new years of publications. Next slide. Our review included longitudinal studies of women who were HIV negative at baseline and were followed over time with respect to their HIV status, and in whom use or non-use of hormonal contraception was measured over time. So we included studies with 2 different kinds of comparison groups. First, we included studies comparing hormonal contraceptive users against non-users of hormonal contraception, and that could indicate either women who were using a non-hormonal contraceptive method, such as condoms or IUDs, or were using no contraceptive method. Secondly, we also included studies that conducted what we call head-to-head comparisons of one specific hormonal contraceptive method versus another specific hormonal contraceptive method. So for example, this might mean that women using injectable DMPA were compared against women using injectable NET-N. All studies measured incident HIV acquisition as the outcome. Next slide. We carefully inspected the methodological quality of each study that qualified for inclusion in this review, and we based our quality assessment framework on the one that we used in our previous review, in which studies were considered unlikely to inform the primary question if they had either of the following fatal flaws: failure to adjust for any measure of condom use, or unclear measurement of exposure to hormonal contraception. And this latter one includes things like failure to include time-varying exposure information, failure to disaggregate by hormonal contraceptive method, lack of clarity in the composition of the comparison group, or inter-survey intervals of longer than 6 months. Studies that contained none of these flaws were considered informative but with important limitations, and we focus in the rest of this presentation and in our paper primarily on these higher quality studies. And just to point out, for the sake of space on some of the slides in the rest of the presentation, these higher quality studies will be referred to using the acronym IBWIL. Next slide, please. In our previous systematic review published in 2014, we identified 22 relevant studies. All of those studies were included and retained in this review update, except for one that was superseded by a newer analysis of the same data set. Of 312 new references that were available and screened, 10 met inclusion criteria. 8 of those compared hormonal contraceptive users to non-hormonal contraceptive users. 1 compared DMPA users to NET-N users, and 1 was an individual patient data meta-analysis which included both types of these comparisons. Next slide, please. So in total, 31 relevant studies met inclusion criteria, 21 from the past review, and 10 that were newly identified. Most studies available compared hormonal contraceptive users to women not using hormonal contraception. But newly available in this review, we also had data from head-to-head comparisons and from the meta-analysis. So after considering study quality, 14 studies in total were considered informative but with important limitations, and 5 of those were newly identified studies. So as I said, in the rest of this talk, we'll focus on these 14 higher quality studies. Over time, the quality of new epidemiological evidence has improved, and several newly published studies have used recently published analytic recommendations or other innovative techniques to try to reduce the potential for confounding to influence the results. Next slide. Next slide, please. So on these graphics, each vertical line represents a study's hazard ratio and 95% confidence interval. And estimates that lean towards the right-hand side of the vertical black line in the middle suggest an increased risk of HIV acquisition, whereas estimates, the boxes in this case, that trend towards the left of that line suggest decreased risk. Studies with statistically significant effects have their marker shown in red. Results from studies that are newly included in this review update are shaded in yellow to show you what's new since the 2014 systematic review. So this slide is looking at those higher quality studies that assessed contraceptive implants. To date, only 2 higher quality studies have assessed implants. Both of those studies looked at levonorgestrel-based implants, either Norplant or J-Del. One of these studies is newly included since the last review. And you can see that neither of these studies suggest a statistically significant increased risk of HIV, although obviously the number of relevant studies and the number of women using implants remains quite limited, which results in wide 95% confidence intervals. Next slide, please. Eleven higher quality studies assessed oral contraceptive pills, and this included 4 new studies. Although one study did report a statistically significant increase in risk, the evidence overall does not seem to suggest increased risk with oral contraceptive pills, and new data strengthen our confidence in that conclusion. So along with the relative consistency in this body of evidence, which seems to hover around a null effect, the growing number of non-significant studies assessing oral contraceptive pills lends more confidence in drawing conclusions about this method. Next slide, please. 6 higher quality studies assessed NET-N, which is a 2-monthly injectable, and this included 2 new estimates. None reported a statistically significant association, although most did trend above 1, and statistical power was limited in many. Data on NET-N is less concerning than in our 2014 systematic review, in which one study did suggest a statistically significant increase in risk. That study from the 2014 review was replaced in this review by a larger, updated, and more sophisticated analysis of that same data set, and that new analysis produced a smaller, non-significant estimate for NET-N. And in addition, other new data on NET-N does not suggest increased risk. So data for NET-N are more limited than for DMPA, but data are less concerning than for DMPA, and increasingly so with this review update. Next slide, please. 12 higher quality studies assessed DMPA or non-disaggregated injectables, meaning that they lump together DMPA and NET-N, although those estimates are likely to be largely comprised of DMPA. All studies assessing DMPA assessed intramuscular DMPA rather than the lower dose subcutaneous formulation, sometimes known as Cyanopress. 5 of these 12 studies suggested statistically significant increased risks, ranging from hazard ratios of 1.45 to over 2, although one of those 5 is not statistically significant under a Cox proportional hazards model. And it's also important to note that some of the non-significant studies had limited statistical power. The 4 newly included studies in this review update for this specific comparison had mixed results. 2 reported statistically significant increased hazards ranging from a 45 to 69% increase, and this included a very large study by Angela Crook, as well as sub-analyses of previously unpublished data from Charlie Morrison's individual patient data meta-analysis. A smaller study among serodiscordant couples by Kristen Wall had non-significant point estimate of 1.34, and a study by Jen Balkus and colleagues had a non-significant point estimate of 1.17, but that study could not disaggregate between DMPA and NET-N. So before kind of summarizing the evidence on DMPA, I'm going to review data on the head-to-head comparisons and also from our statistical meta-analysis. Next slide. Two studies provided head-to-head comparison or method-to-method comparisons. These studies may potentially have reduced confounding by comparing women who use different types of hormonal contraception to each other, rather than comparing contraceptors to non-contraceptors or to women using non-hormonal methods. A limitation of this type of comparison is that we have less understanding about the baseline risk of the comparison group. Lisa Noguchi's analysis of voice data reported a 41% increased risk of HIV acquisition in DMPA versus NET-N users. Charlie Morrison's IPD meta-analysis considered 3 head-to-head comparisons. DMPA was associated with a significantly increased risk of 30 to 40% when compared with either NET-N or combined oral contraceptive pills. However, risk was similar when comparing NET-N against combined oral contraceptive pills. Next slide. Statistical meta-analysis of observational data is controversial, and we've been previously reluctant to conduct one given differences between studies, concerns about confounding, and the potential for spurious precision when statistically combining results from observational data. The simplicity of communicating a single estimate is very attractive, but it runs the risk of being overemphasized despite potential quantitative or qualitative differences between the component studies. However, we did find low evidence of statistical heterogeneity between studies, and so we did conduct a meta-analysis, although we acknowledge that qualitative differences between studies may still be important. Our meta-analytic estimate for DMPA was 1.4, which would suggest an approximate 40% increase in risk of HIV acquisition with risk of DMPA, and this estimate was statistically significant with a confidence interval of about 23% to 59%. So these results are similar to other meta-analyses that we discuss in our systematic review. Those meta-analyses were of variable quality, and they all included slightly different sets of component studies, but interesting, they did all reach rather similar point estimates. Next slide, please. Our manuscript also describes all of the factors that have been examined in various studies for potential effect modification, and 3 of these are mentioned on this slide. For the sake of time, I'm just going to touch on the first today. There had been a somewhat pervasive sense a couple of years ago that any potential DMPA HIV acquisition association was even higher amongst younger women as compared to that same association in older women, or in technical terms, that age modified the effect of DMPA on HIV risk. However, in 10 studies assessing for this, only 1 has found a significant interaction for age. So this means that most studies have suggested that any potential effect of DMPA on HIV acquisition is likely to be similar across all age groups. Next slide, please. So in sum, there remains no data on patches, rings, or hormonal IUDs. For implants, very limited data pertaining to levonorgestrel implants do not suggest increased risk, but we need more information. A substantial amount of data for oral contraceptive pills seems reassuring. For NET-N, concern has reduced since our previous review, but data are still somewhat limited and additional investigation would be useful. For DMPA, we have the largest number of higher quality studies available as compared with other methods. Point estimates in the new higher quality studies seem to be converging around an association that ranges between 1.2 and 1.6. While we cannot rule out confounding in these observational data, several new studies suggesting increased risk for DMPA had few study weaknesses apart from being observational. New data from both types of comparisons heightens concerns around DMPA, particularly when considered in conjunction with the growing and generally reassuring evidence on the other contraceptive methods studied, including other injectables like NET-N. So an important next step will be for the World Health Organization to determine whether these data warrant a reconsideration of global guidance for DMPA, And Dr. Chiari, I believe, will be saying a bit more about that piece in a few moments. Next slide, please. So for my last few slides, I'm going to shift gears away from the systematic review a little bit and just make a few points that I'm hopeful will be helpful for thinking about implications. I noted earlier that our statistical meta-analysis generated a hazard ratio of 1.4 with DMPA use. So this is often translated as a potential 40% increase in risk of HIV with use of DMPA. But a lot of people tell me that it's hard to know what a potential 40% increase in risk really means. And the next few slides really try to explain that from a few different perspectives. For an average young woman in South Africa, for a woman in a nonspecific developing country who's having sex with an HIV-infected partner without a condom, and for a policymaker trying to consider how to balance the possible risks and benefits of DMPA. And I just want to note in advance, I'm very grateful to Dr. Jennifer Smith and Professor Marie-Claude Boilly for their help in developing the content of several of these slides. Next slide. So what would a potential 40% increase in risk with use of DMPA mean for an average young woman aged 15 to 24 living in South Africa? Without using DMPA, she would have an approximately 2.4% chance of contracting HIV over the course of 1 year. If DMPA increases the risk of HIV acquisition by 40%, and if that same young woman used DMPA, her risk of HIV acquisition would increase to 3.3% in the course of a year. These are, of course, approximations, and it's important to note that this young woman's individual risk would, of course, depend on many factors, such as whether her sexual partner or partners are HIV positive, circumcised, or using ART, whether she's using condoms or PrEP, how often she's having sex, and a range of other factors. Next slide, please. Taking a slightly different view, this graphic shows what a potential 40% increase in risk would mean for women having vaginal sex with an HIV-positive male partner without condoms, according to the number of sex acts. So let's focus on the developing countries, which are represented by the two lines nearest the top of the graph. The blue line represents HIV risk for a woman in an average developing country who is not using DMPA. The red line represents that woman's risk if she is using DMPA, and if we assume that DMPA increases risk of HIV acquisition by 40%. The red arrows are just a way to emphasize the difference between the lines, showing risk with and without DMPA use. So for a woman in a developing country who has 50 vaginal sex acts, which I've circled in black, that's about once a week, with an HIV-infected male partner and does not use a condom, her HIV acquisition risk is about 14% without DMPA and about 19% with DMPA. Next slide, please. If DMPA does increase risk of HIV, how might policymakers think about balancing the risks and benefits of DMPA? We know that DMPA is one of the most common modern contraceptive methods in many sub-Saharan African countries, and that it prevents a lot of unintended pregnancy and therefore a great deal of maternal and infant morbidity and mortality. So how can we think about balancing those benefits against potential increases in HIV risk? And this is a graphic from a modeling study that essentially suggests that the impact of decreasing use of DMPA use varies substantially by the epidemiological context in each country. So things like existing HIV levels, the birth rate, the maternal mortality ratio, the contraceptive method mix, and the true effect size of the DMPA-HIV Acquisition Association all come into play. In countries like South Africa, which you see represented in dark green, reducing reliance on DMPA would likely reduce deaths overall, since reductions in HIV-related deaths would likely outweigh increases in maternal mortality. And indeed, South Africa has already taken some steps to expand their contraceptive method mix. On the other hand, in countries like Madagascar or Indonesia, which are shown in red, reducing reliance on DMPA might increase deaths overall, assuming a 50% increase in risk of HIV acquisition with DEPO, since increases in maternal mortality would outweigh decreases in HIV-related deaths, unless women have access to and agree to use more highly effective methods of contraception, and assuming that those methods don't increase HIV risk. So the take-home point of this slide is really that a policy of do no harm might mean different things in different countries. And I'm really happy to say that modelers at the Imperial College of London are currently developing country-specific models to really consider these issues in greater detail at the country level. Next slide. So to wrap up, I just wanted to note that our new systematic review has been published in the journal AIDS. It's currently available to anybody who has a subscription to that journal, but it will be made available very soon open access, which means that it will be free of charge to read for anybody who clicks on the link. And for people who are interested in this topic, I also encourage you to read an opinion piece that we simultaneously published in AIDS that explores what we know and don't know about levonorgestrel, a different type of progestin, and HIV risk, as well as drug interactions. Next slide, please. So I really look forward to the discussion today and to hearing the other presenters' comments. And if anybody has additional questions on the systematic review, please feel free to get in touch with me at the email address shown here. Thank you so much.
Hello, Dr. Chelsea, thank you so much for your presentation. I think now we need to have the second presenter because we have a specific session where we are going to have questions and answers. I can see some people have already asked the questions, but we shall have them during that session. I now take the opportunity to invite our second presenter who is going to present on the WHO's plans or the next steps based on the latest systematic review of hormonal contraceptives and the HIV relation link. And our second presenter is Dr. James Chiari. Dr. James has over 20 years experience in teaching, clinical practice, and research in the field of reproductive health, focusing on HIV and AIDS, sexually transmitted infections, and family planning. And he is the coordinator of the Human Reproductive Program at the WHO, World Health Organization. He is also a co-author on the systematic review, and he has been a valid partner to the civil society in facilitating dialogues and engagement on this very important issue. So, Dr. James Chiari, the floor is yours. Thank you.
James, it's *7 to unmute your line.
Hello.
Hi.
Hello, can you hear me?
We heard you beautifully. Happy. We heard you beautifully. Thanks so much. And I think everyone figured out, but that's Margaret Happy, who is the coordinator of the Advocacy Working Group. Dr. Chiari is on the web. I can see. James, are you able to, do you need us to dial into you, and can you use the chat window to let us know if that's the case? It's *7 to unmute. Dr. James? Okay. Let's see. Thank you guys for just a minute while we sort out the technical side of this. James, if you can hit *7 on your phone, that might unmute you.
Am I now unmuted?
You are perfect. There you are. Off you go. Thank you so much for your patience, everybody. We can hear you.
Okay. Yeah, thank you, Emily, for sorting out that technical hit. And thank you also to the organizers for inviting WHO to participate in this webinar today. And for more details on what I'm going to speak about, there's a statement of WHO's position and plan that can be found on our website under the Reproductive Health and Research Department. And thanks to the organizers for including the link in the invitation to the webinar. So in brief, what the statement says is that we are committed to convene an expert review group later this year to examine the links between use of various hormonal contraceptive methods and women's risk of HIV acquisition. We are currently looking at possible dates in late November or early December this year. And the name and bios of potential experts will be posted on the WHO website for 2 weeks, about 1 month before the meeting. And we will invite anybody who has a comment. It will be a public forum. You can comment on the experts and on their conflict of interest if you see any. Then also WHO commits to continue engaging with stakeholders and monitoring and reviewing new evidence and providing guidance accordingly. And really this is the reason that this systematic review was commissioned by us. We also note that most of the data on hormonal contraception, including for oral contraceptive pills, injectable Net10, and for levonorgestrel implants, continue to indicate no association with risk of HIV acquisition, and the data is largely reassuring. And we also note that despite the study's limitations, these new data do strengthen existing concerns about a possible increase in risk of HIV acquisition in women using DMPA. And another important issue that we've noted in our statement is that there's an ongoing randomized trial to compare the risks of HIV acquisition among women using different contraceptive methods. And we believe the trial will provide evidence as to whether using any of these methods causes an increased risk of women acquiring HIV. And thanks to the organizers, I think this will be one of the presentations that we'll be hearing today. We note the importance of determining what guidance should be given to women, particularly in sub-Saharan Africa, where high rates of HIV coincide with high use of DMPA injectable contraception. And finally, WHO emphasizes the right of women and men to have the latest and best information and to access their preferred options when choosing a contraceptive method. So to conclude, I say we are very happy to be part of this discussion, and we will continue being engaged on this issue and relooking on our guidance and reviewing the evidence as needed. Thank you.
Thank you so much, Dr. James Chiari, for your presentation and also for highlighting the areas where we need to be alert and participate. At this point in time, I would like to take the opportunity to invite our third presenter. He's going to give us an update on the evidence for the contraceptive options and HIV outcomes trial. He is Dr. Jared Baton. He has been doing his research focusing on the prevention of HIV, the type of HIV number 1, and other sexually transmitted diseases, including clinical trials of novel prevention interventions, epidemiological studies of risk factors for HIV type number 1, transmission and behavior, translational and implementation science research, which is aimed at optimizing prevention delivery. He is also a co-chair of the ongoing ECHO trial, which is being carried out in 4 countries now, that is exploring the relationship between HIV risk and use of specific contraceptive methods. And he has been a close collaborator with the advocacy working group on this very important issue and many other issues which are of great importance to us as women. And so, Dr. Jared Baton, you're welcome, and now the floor is yours. Thank you.
Thank you. Thank you. Good morning, good evening, everyone, and thank you for this opportunity to talk. This is such an incredibly important topic, and I personally am just thrilled by the interest in this webinar and, of course, the very, very good science and advocacy being done around this question. Next slide, please. So I'm speaking on, as an update on the ECHO study, which interfaces, of course, very importantly with all emerging information on the safety and HIV risks of different contraceptive methods. I am just one small piece of the ECHO consortium, and you can see here all of the members who are bringing this important study together, both at the sponsor level, jointly done by FHI 360, VITS-RHI, and University of Washington, where I am, with the partnership of WHO, and then the partnership of a number of other investigators and study sites, and funders who are making this work very much possible. Next slide, please. ECHO is a randomized trial, and a randomized trial, if done well, provides the highest quality evidence for a question. And there was much debate and much question before whether a randomized trial could be done and whether it was the right thing to do for this question. And after considerable scientific and advocacy consultation prior to initiation of this trial, it was decided that a randomized trial would be important to understand the relative risks and benefits of different contraceptive methods as they relate to HIV, particularly for providing guidance at the level of persons who make policy and program decisions, to help the counseling for clinical providers, and importantly to permit women to make fully informed choices of to weigh the relative risks and benefits of different contraceptive methods. And that is the underlying goal of ECHO. Next slide. We are hoping and charged with answering the pressing public health question of weighing the relative risks, most importantly HIV, and benefits, including pregnancy prevention, of three commonly used, highly effective contraceptive methods among women who have desired to use contraception. Next slide, please. Many of you have heard about ECHO, but here are the basics of it, condensed onto one slide. It is a multi-center open-label trial with random allocation to injectable depomedroxyprogesterone acetate, the levonorgestrel or Jadel implant, or a copper IUD. Among women who are sexually active, HIV uninfected, age 16 to 35, who live in areas of high HIV risk, who are seeking effective contraception, and who, after considerable counseling and consent, are willing to be randomized to any of the three methods. The trial is scheduled to enroll about 7,800 women, and the outcomes, of course, are HIV, with design to be able to observe a 50% difference across the three methods. As Dr. Polis pointed out just a few moments ago, a degree of increase that would be of great importance from a public health point of view, as well as outcomes including pregnancy, adverse events, and method continuation. Visits are quarterly for up to 18 months per woman and about 36 months for the entire study. The study is grounded within individual risk reduction counseling, condoms, partner testing, STI screening, PrEP, and microbicides as they roll out into care, with linkage to HIV care for women who acquire HIV, into contraceptive care for all women as they finish their follow-up. At 12 sites in Kenya, South Africa, Swaziland, and Zambia. Next slide, please. In planning this study and in doing this study now, we have put considerable effort into make sure that it's being done well. Because the argument that a randomized trial can provide the kind of information that will change policy, inform clinicians, and provide the very best information for women to making choices is a great burden, and we want to make sure that we do it correctly. So we defined early on that we would be doing the study well in terms of its accrual, the acceptance of the randomized method at the time of entry into the study, retention of participants, rate of contraceptive discontinuation, HIV incidence, and quality of study performance. We defined before the study started levels at which these would be of concern or unacceptable to continue the study, and we are holding to make sure that we do the study well enough so that we can provide the clearest answer possible. Next slide. The study protocol was reviewed and approved by institutional review boards at FHI 360, who coordinates the operations for the study, and then, of course, with each study site. An independent DSMB, including a multinational group of diverse scientists, reviews data on participant safety, study conduct, scientific validity, and integrity of the trial, scheduled every approximately 6 months. A safety oversight committee reviews all the safety data monthly and has 24/7 availability for study sites. A global CAB has been chartered, as well as cabs at each site, and each site has an active GPP plan. And the trial meets all regulatory requirements, both in the US and in each country. Next slide, please. As we've begun and done ECHO and thought about what we've begun to think a lot about what the outcomes could be, because we have to plan, all of us, for what outcomes of this study may be. There may be no difference in HIV risk across the 3 arms. That the risk of DMPA compared to a risk of 2 different methods, implants and IUDs, which have very limited information right now about the relative HIV risk, their risk may be comparable, which would provide new information, incredibly important new information, that might suggest that each of these methods has a place. There may be differences in HIV risk, and here are only some of the possible scenarios. The implant may be of lowest risk, which may strengthen arguments to increase access to the implant. An IUD may be of lowest risk, which would increase interest in strengthening access to the IUD. And DMPA may be of highest risk, which may help women and programs shift to less use of DMPA. Next slide, please. There have been many questions in the consultation moving up to the initiation of ECHO. Questions about whether the question is already answered. And we, in planning the ECHO study and continuing to review the evidence on a continuous basis, have explored that while there are studies suggesting that contraception, particularly DMPA, may be associated with HIV risk, the evidence to date has not been sufficiently definitive to change policy and program. And observational data may be limited by confounding. And importantly, it is not clear if the alternatives would be better, because the alternatives have incredibly limited information to weigh their relative risks compared to DMPA. We have weighed the ethics about whether it is ethical to randomize in the context of informed consent, and whether it is feasible to conduct the study, agreeing to randomization and doing the study itself. I will say we have had tremendous input in the study that we appreciate greatly, both scientifically and from the advocacy community, and it has shaped the conduct of this trial to be done in its very best way. And I can provide information right now on the next slide about where the study stands, which is in a very good place. Next slide, please. ECHO began in December of 2015. It is now open at 11 of the 12 study sites, and its current enrollment is more than 2,000 women, more than 25% of the estimated number for the study. There have been very few, I will insert an editorial, very few method refusals in front of few there, and very high retention so far. The DSMB, the independent DSMB, had its very first meeting in August. It reviewed the information from this most recent systematic review and meta-analysis and recommended that the ECHO trial continue. So we are continuing the ECHO trial at this time. There is ongoing review of the informed consents and participant counseling materials as new information and recommendations emerge. Next slide. In summary, in the absence of the ECHO trial, the argument has been that the observational evidence may not motivate change in policy and program, and messaging will continue to be challenging for providers, for policymakers, and for women. That HIV risk may exist in truth, but policy would not change, and programs may not change, and unnecessary infections would continue to occur. Or HIV risk may not exist because of confounding in the observational evidence, and policies and programs may change with potentially serious negative consequences for maternal morbidity and mortality. For example, if women stop using contraception altogether or use contraceptive methods that are less effective. ECHO is designed to provide the highest quality evidence so that women will have the highest quality information to make the best informed choices for their individual case. Providers will have the best information for contraceptive counseling, and policymakers will have the highest information for making program decisions. On behalf of many, many people who are contributing, and many of you who have made ECHO a better study, thank you very much, and I look eagerly forward to more discussion on this. Thank you.
Thank you so much. Thank you so much, Dayton, for the update that you've given us. And now we are having two representatives of the civil society, Yvette Raphael and Eunice Sinyemu. Yvette Raphael is a human rights activist with a focus on people living with HIV, young women, and lesbian, gay, bisexual, queer, and intersex communities. She has worked in HIV and AIDS education in the safety and security sector, and she's a founder of two empowerment and support organizations for people living with HIV, and she's currently helping to launch a new prevention advocacy organization. So Yvette, you're welcome to make a presentation or a statement on behalf of the civil society on HIV and the hormonal contraceptive relationship in relation to the current systematic review. Thank you.
Okay. All right. Good afternoon, everyone. Thank you for all the previous presenters, and thank you for the introduction, Happy. Family planning options and services has always been a very sore and sensitive issue for women, especially women from sub-Saharan Africa and Africa. And it's especially a sore issue for women living with HIV, since women carry the majority of the HIV/AIDS burden, and since so many young women living with HIV. HIV/AIDS prevention advocates and women living with HIV keenly followed and engaged, debated, discussed the relationship between hormonal contraception and HIV/AIDS risk at different levels since 2012. In October 2015, the WHO posted a new statement on hormonal contraception and HIV, which contained a range of inaccurate information. In November 2015, HIV prevention advocates and women living with HIV wrote an urgent letter to the WHO calling for an urgent action on this statement. WHO responded on April 5th and agreed to revise the statement to correctly characterize the evidence, revise the statement to specifically reference the right of women to know about the uncertainty regarding the MPA and the HIV risk. WHO stated that it will not add a reference to additional prevention methods beyond male and female condoms. We as advocates and women living with HIV would like to know how far has WHO gone with the review of the communication strategy considering the new data. We'd also like to be involved in this process. What steps have been taken by the Guidelines Advisory Committee in relation to the new data, and activists, women living with HIV would also like to be involved in this work. We need clear guidance for increased method use, and also technical guidance should not be limited to condoms, male and female, but also to consider oral prep and new prevention methods as currently in the field. I would hand over to my comrade now.
Yeah, thank you so much, Yvette, for your presentation. And now we are going to hear from Eunice, who is also a representative of the civil society. She is a committed activist for women's health and rights and an effective HIV response. Presently, Ms. Eunice Sinyemu works as the Zambian country manager for the Tropical Health and Education Trust. She was the executive director of the network of Zambian people living with HIV. Eunice, will take over from Yvette. Hello, Eunice, are you online? Hi, Eunice, can you hear me?
We just lost Eunice.
Oh, sorry.
Now.
Okay. All righty. Do you want me to continue?
Yes, please. Can you take over from Yvette?
No, it's Yvette speaking. I'm worried about Eunice getting on the line.
I'm going to go back. I lost Eunice, so I'm going to go pick up Eunice. But I do know that we are moving into the top of the hour. So I'm asking people, hope that we won't lose presenters and other folks, and maybe we'll persist a little bit longer. But Happy, perhaps you can begin to facilitate some Q&As while I get our colleague Eunice back on the line, just so that we use all the time efficiently. We have a couple of questions that have come in the comments. One on studies of cyanopress, if any are underway, and one about whether equipoise truly exists now, that equipoise and echo truly exists given the systematic review. So just capturing those from the chat room and turning back over to Margaret Happy to facilitate Q&A. So Jared, you and I know we have Dr. Helen Reese also on the line. So if one of you wants to sort of address the equipoise question, that would be great. And I don't know who, perhaps all of you have insights into studies on cyanopress. Remember, again, it's *7 to unmute your line.
This is Jared. I'll speak. Encourage, if Helen, please jump in. I'll speak briefly to cyanopress. I am not aware of any studies with assessing cyanopress and HIV acquisition with the specific question of new HIV infection. There are potentially some smaller studies of biological characteristics associated with cyanopress. I think is an incredibly important question. The question of equipoise, and I would encourage anyone else from the ECHO team to also chime in. The ECHO team has continuously reviewed information regarding all three of the contraceptive methods that are part of the study and HIV risk, both including the DMPA, but including both the implant and the IUD. Where there is considerably less information since before the study started. We are in continual contact with the DSMB as well as the Global CAB and our study investigators and other policymakers to understand weighing the relative risks and benefits. We look forward eagerly to the review by WHO coming up very soon to understand how to interpret and weigh recommendations regarding DMPA. It is important to remember for one of the reasons that ECHO was designed was to weigh DMPA risk relative to other contraceptive methods, because of course women's best choice is to weigh her own options across different contraceptive methods rather than one contraceptive method versus nothing, which most of the observational studies were designed to assess. There is very limited information for the IUD as an alternative contraceptive method and what risk of HIV it might propose. It is certainly not an inert contraceptive. In addition, there is quite limited information for the implant. As you saw today, while it may be reassuring, it is based on a very small number, a very small piece of data. And so we may not know enough to weigh whether it is a viable and safe or better contraceptive method with respect to HIV risk. Of course, it is a very safe contraceptive in general, however, which is why it is being compared in ECHO. Others, would you like to, if others are on, I encourage them to weigh in. Thank you.
Thank you so much. Thank you so much for responding to that question. I think in reference to the presentation from Yvette, I think she had some questions, and those questions were directly directed to WHO. I don't know whether Dr. James Kiari is still online so that he can respond to some of those areas as we wait for Eunice Sinyeme to give us her statement.
Yes, happy. I'm still online.
Yes, Yvette, in her presentation, she has some specific questions which she asked in relation, I think, to communication strategy, but also requesting for participation in the processes of reviewing the current statement. So can you help and respond to her question as we wait for Eunice Sinyeme's statement? Thank you.
Yes, thank you very much. I think any of the experts or maybe people on this call who would like to participate as this is what we call an advisory group that will basically advise WHO or in the process of developing the new guidance, either reviewing it, either deciding to keep it the way it is, or maybe changing components of it. Please feel free to send us an email. And I think Emily and the organizers have my email. I do not mind sharing, so we can share you can share my email, and what we will probably need from the person would be a CV, and then there is a process within WHO by which experts are identified. There is a standing group that has been formed to identify experts, what we call our guideline steering group on contraception, and then that is followed by a review of the people by our legal department, and also a review by the guideline steering committee, and a review by what is called the conflicts department. So there is a process. So although I cannot promise that any specific person will be included, I think it's always good to have a wide pool, and maybe whenever we think of reviewing guidelines. So if people are interested, they can send me an email with their CV, and also in the CV, please indicate the area of expertise, if it is hormonal contraception, if it is in health systems, and so on. But other than the experts, of course, we'll be inviting also representatives of the communities that are affected by this issue also. Thank you.
Thank you so much, Dr. James Kiari, for the response, and I hope Yvette is still online and she has taken note of the response. So at this point in time, because I'm not yet getting any indication of Eunice's name.
We may have Eunice back. Eunice, can you speak to see if people can hear you now?
Hello, Eunice. Are you online?
Well, these are the challenges of engagement, transcontinental engagement. So we'll keep trying and keep doing questions, I think. I'll just read out another one from the chat room. It seems clear from the excellent analysis done by Dr. Polis et al. That there's a small number of countries where it makes sense to rapidly increase the method mix and counsel women on the potential risk of DMPA. We heard that South Africa is already moving in this direction. What else can the global health community do now while we are waiting for the ECHO results to advance increasing method mix in those green countries? And if you remember the map, the green countries are the ones where this issue is really critical. So over to presenters to engage that, including Eunice, if we get you back, and Yvette, because I know you're both working on this very issue.
It's Helen here. Can you hear me?
Yes, we can.
Yes, we can.
I wonder, so it's Helen Reese speaking. I'm one of the co-investigators on the ECHO trial, but I'm also very involved in developing and supporting the health department in South Africa around expanding the method mix. So indeed, because as we saw on that map, if the impact of DMPA in increasing HIV is real, South Africa would be a country where changing contraceptive use would have the biggest impact. So we very carefully pushed and supported a policy that increased implant and re-promoted the intrauterine device. It's proving, and this is why it becomes very difficult and modeling becomes difficult, because what happens in the field is different. It's proving very difficult to get the implant uptake up. Initially, we had a big rush to implants and we had a big push, but now we literally have implants expiring in warehouses for a whole number of reasons. But it means that women are still choosing to predominantly use DMPA. And so it remains that, and the implant use has gone right down. So one of the reasons, not the only reason, is the bleeding pattern that women don't like with implants. The second reason is healthcare providers find that in extremely busy circumstances in primary healthcare environments, that putting in an implant takes a lot of time. It doesn't matter that further down the road the woman won't need to come back. It is quicker for them to give DMPA. So there are a whole host of reasons why changing patterns of prescribing are challenging. And we are trying to analyze this in South Africa at the moment and look at how we can once again change this. But this is why, the earlier question, sorry I couldn't get online, about does equipoise still exist? I think that's a critical question about the ECHO study, but I think the question we all have to say to ourselves at this point is, are we sufficiently confident to say there's definitely an increased risk to women in front of us and to policymakers? Or are we still saying, okay,
hello, Emily?
We still have a level
hello,
of
Emily?
Hello?
Hello, can you hear me? Hello, can you hear me?
Yes.
Sure, Eunice,
yes,
it sounds like we can finally hear you.
Go ahead,
I think Dr. Reese is just finishing her remarks. Eunice, Dr. Reese was just finishing remarks, and then we'll go over to you now that we finally got you back.
Okay.
Yes. Well, I think I've finished, but I'm just saying that in truth it's proved to be quite challenging to expand the method mix, even with absolute political support and investment. This is a challenge, and we're going to have to grapple with this for many reasons in the future. Over.
Eunice, over to you now.
Oh, hi. I think for me, really, a number of issues that has actually raised. I just wanted to find out, in terms of the study itself, how far it has gone in terms of engaging, civil society to look at what is happening, how the study is going. So my comments were really to say that there is a greater need for all the women to have the access, especially those who are utilizing the hormonal contraceptives. And I think I've sent a question to Dr. Gerard to say, in his slide, he talked of challenges that he's facing. Well, they are facing challenges that are there in terms of messages. And I wanted to find out what those challenges are and why we have challenges on this study in terms of messaging.
Thank you so much, Eunice. I think your question is directed to Jared. To Dr. Jared Dayton. So I request that he responds to that question, and then we can proceed with more questions and answers. Thank you.
Thank you, and thank you for the question. I think the question was about challenges within the trial. I will say that we have been incredibly impressed to date with everyone's ability, with the support that this trial has received, the interest that the trial has received, and the great ability to do the trial. So we had anticipated, and maybe because we had anticipated so many, we anticipated many things that could be challenges in the trial. To be able to recruit people, to be able to create the counseling and consent that would be able to very clearly the question being asked and the information as known at this time, and information that would change over time, as we would expect, and we are seeing already, and the ability to engage women into making a decision to be randomized to a contraceptive method and then to continue. But as I had on the second to last slide, where there was a little bit of summary of where the trial is, we have been very, very surprised by how well the trial is going, and I think in great part that is because of the anticipation of this, and in great part is because of the full engagement of the study team, both at sites and those coordinating, and the CABs at each site, and the global CAB, and other advocates and scientists who have weighed into the design of the trial so that it is done well. We are seeing very little refusal of the randomized method. We're seeing high continuation both in the study and of the contraceptive methods that have been assigned. And this is in the context of evolving information on all of these contraceptives, as well as for the IUD, for example, very limited use in the geographic areas where many of the sites are, and so it is an example of expanding method mix and expanding the clinical expertise for delivering that method mix in this wide geography where the study is being conducted. Thank you.
Thank you so much, Doctor, for the response. We have here a question from Nina. She says it's a comment, but also with a question. She says that it seems clear from the excellent analysis done by Dr. Paulis.
Sorry, Margaret.
Margaret,
this is one of the ones that I posed, but we do have one from Cameroon. We're both looking at the same chat window. People who aren't looking on the web. So Helen addressed that in the context of what they're trying to do in South Africa's method mix. But I wonder if you can see the question that came in concerning young girls in Africa and particularly in Cameroon.
Oh yeah, there is a concern. There is a question here concerning the young girls in Africa and particularly in Cameroon. That what do you propose for those who are forced to marry early and who cannot avoid pregnancy and HIV, because they will need their parental or husband's authorization, who will not be given to them. So this question, I think, needs response from all the presenters. Hello.
Hello. Could you repeat the question?
Can you hear me?
Could you repeat the question?
I can hear you, but very slightly. Can you repeat what you said?
The question is about, and it's from, I think, a participant. It came in via email in West Africa and possibly particularly Cameroon, about what to do and say to young women who are forced to marry early, who cannot avoid pregnancy and HIV because they need parental or husband authorization and they don't get it. So any lessons, and Yvette, I know you've worked with young women a great deal, any lessons in helping women access the tools that they need in contexts where they may not have autonomy, either from ECHO or from programs or from work on the ground?
Yes, Emily, good afternoon, everyone. I think for us as women and for activists and women, female advocates, I think the ECHO trial is the perfect opportunity for us to do more work around contraceptive and contraception education. I think we have seen and we can see that a lot of times the choice of contraceptive method is almost never what the young woman chooses. And as some of the presenters have alluded to, is that it's often the choice of the healthcare worker or of a male partner. So this is an opportunity for us to educate, and what we'd like to see is education around contraception and contraception options, what all of these methods mean for a young girl in Africa or around the world. So we would like more of that seeing happen, and we know that the young girl struggles with that choice because it's almost never her own choice. So HIV and AIDS would be something that you had to live with without it being her choice.
This is Chelsea Polis. I'd like to jump in as well and to concur with what the last speaker said about the importance of education and teaching people about the variety of contraceptive methods available. I'd like to add to that I take much inspiration from the HIV advocacy community in its efforts to advocate for treatment and for new prevention options, and I think I would really love to find some way to harness the energy and potency of those movements to direct some of that towards advocacy for funds to support the development of new contraceptive methods that meet women's needs, that could meet the needs of a young woman who may need to use a method covertly, which is why many women do prefer DMPA, because they can use that method quite covertly. But to harness that advocacy energy for funding for contraceptive development and contraceptive programming. There's a new paper that came out recently called Placing Contraception at the Center of the HIV Prevention Agenda by Tamarin Crankshaw, Jennifer Smith, and Mags Basinka that gets into some of these issues of the importance of really thinking about the centrality of contraception in women's lives, living with or without HIV. And I hope that we can learn from the experience of the HIV advocacy community to really help USAID and other organizations that focus on development and expanding access to contraceptive methods to women around the world. Thank you.
Thank you so much for the response. Is there any other presenter who would like to build on that? Can we hear also from WHO representatives? Dr. James.
Yes, yeah. Sorry.
Dr. James, are you still online?
Yes, I'm still online. Sorry, I was on mute.
Yes.
I hope everyone can hear me. So I think this is a very challenging issue because it deals with a population that is at high risk, and we know that these are people who we find in all the countries. And for us in contraception, always I think it's to be respectful of the people and their choices, and to work within the context in which you find them. And we do have guidelines on adolescents, how we have guidelines on prevention of domestic violence. I hope we have guidelines, WHO guidelines on prevention of domestic violence and what people can be able to do, particularly the role of healthcare workers in this context. And these are some of the things that we should take into consideration. And I think what I will do, maybe I'll send out a link to some of our guidelines that can help healthcare workers assist young girls that are in this kind of situation. Thank you.
Thank you so much, Dr. James. Is there any other question?
Well, it's Helen here again. Just a quick
yes,
comment.
Yes, Helen, we are glad you're also online.
Thank you. just a quick comment on that last question. I think that we have to raise our voices just about women's status as well. Contraception will not solve this, unfortunately. I mean, we want to give those as tools for women, as an empowerment tool, but hand in hand with this, we can't just use contraception or the HIV epidemic. The voice has to be about the status of women throughout this continent and beyond, because I think that voice is simply not being heard. We hear about Boko Haram and we close our eyes again. We're so used to it. And I just think that that's a voice that we need to find again. Now, having said that, I do agree that ECHO is already giving us really critical information that we haven't previously had about how to successfully offer women in an acceptable way and get healthcare workers to offer women these 3 methods of contraception in a way that we're not really seeing routinely in services. So we're hoping to learn other things as well from the study. Thank you. Over.
Thank you so much. Thank you so much, Dr. Helen, for the response. Is there any other question? I can see, Hajara, you have your hand up. Can you unmute your phone? Hello, Hajara? Hello, Hajara?
I think we may have
lost her. We are missing Hajara.
Yeah. So just while we're wrapping up, I think, and I really appreciate everyone who stayed on past the hour for this really important issue. We will get an email from all participants. We'll get an email with a recording link, but we'll also try to build in some of the other resources that Dr. Chiari and others mentioned, including a way to get in touch, as he so generously offered people a chance to email to express their interest in being part of the expert stakeholder panel. So Margaret and I will work together to have as much as we can reflected all of the resources alluded to, the open access version of Chelsea and her colleague's paper and the op-ed and so on. And just on behalf of AVAC, before I turn it back over to Margaret, I just really want to say thank you to everybody who joined, who thinks about this and who works on this issue. Over to you, Margaret, maybe to help us close.
Thank you so much, Emily, and I would like to thank all our presenters now. I want to take the opportunity to invite Miss Lillian Morocco. She's the Executive Director of ICW Eastern Africa, to make her closing remarks. Hello, Lillian.
Hello.
Yeah, Lillian is online.
Hello.
Yes, Lillian, we can hear you.
We can hear you, Lillian. Please just speak up as loudly as you can.
Thank you very much for everybody who has been able to participate in this call. Thank you to our presenters, and thank you to AVAC for connecting all of us together. This is an important process and an important meeting for all of us, but I think for me the most important is that we are able to connect with the research team, we are able to link up with the WHO, and together we are all looking for positive outcomes. And my final word would be to say I think we need to continue having these engagements because we learn and share a lot, and together we'll be able to make it better for women who are looking for options and choices. Thank you very much. And thank you, Margaret, for sharing.
Thank you so much, Lillian, for the remarks. We have very many questions coming through the chat room, but we are going to record all these questions, and we shall also continue linking up with all the presenters for response to these questions, and we shall keep everybody posted. So to build on what Lillian has said, thank you so much for your active participation.
Thank you.
And bye for now.
Bye for now.
Bye. Bye.